Hello and welcome to your anemias lecture by me, Miss Gilbert, for RNSG 1036. Our standards for this portion of the lectures will cover these three standards about collaborating with the coordination team, teaching clients, and implementing nursing interventions. So first, what is anemia? Anemia is when you don't have enough cells of red blood cells, enough hemoglobin carrying that oxygen for us, or not enough hematocrit. So it can be that they have the right number of red blood cells, but they're immature. They have hemoglobin, but again, they are shaped incorrectly, the red blood cells, so they can't carry the hemoglobin, or the hemoglobin is not adequate in carrying the oxygen. Something that is causing a deficiency here as a result of not enough or immature, inaccurate, normal blood cells is anemia. The most common indicator that we refer to is the hemoglobin, though. So knowing these normal levels are going to be necessary. So for men, a hemoglobin less than 13.5, and in women, a hemoglobin less than 12. These are going to be your numbers to memorize that may indicate that a client is anemic. So then why? Why do they have anemia? Is it due to a dietary deficiency, dietary enzyme deficiency, even though that they are eating the required foods, but their body's not taking it in? Is it a genetic disorder then? Is there an issue with their bone marrow, that they're not producing the right kind of red blood cells, or immature red bload cells are being kicked out before that they have time to fully become red blood cells that have the carrying capacity into the circulatory system? Or like trauma, excessive bleeding is another one, major one that we look at, especially after surgery or any kind of trauma for any excessive bleeding, blood loss type anemia. So what does anemia look like? There's multiple different realms of anemia, but the basics of anemia I have here on your left-hand side. Usually the skin is very cool to the touch. They don't tolerate cooler temperatures because they're already quite cool. They have brittle or concave nails, and they're very pale. Cardiovascular-wise, they have a rapid heart rate, and it increases after meals and activity because they're not used to that increase in metabolism, increase cardiovascular-wise. So very little things overwhelm their cardiovascular system. They may have abnormal heart sounds like murmurs or gallops, and orthostatic hypotension can occur as well. Again, very easily overwhelmed. Respiratory-wise, they can be breathless on exertion. They have a decreased O2 saturation, and neuro-wise, they are very fatigued. They have an increased need for sleep, and they have reduced energy levels. Now you'll see here in the picture, in the items that are in red in severe anemia, this is not like your typical barely, minutely anemic. This is more like chronic anemia that has now developed into a complication. So don't look at these as common symptoms. This is concerning symptoms. So fainting is a concern, chest pain, angina, and heart attacks. So in addition to those symptoms, you may have symptoms that are specific to the type of anemia. So as we go through the different types of anemias, you'll see different things that may be on presentation. So first, with blood loss anemia, the blood loss may be due to, like I said, surgery or trauma, but they're not just losing red blood cells, right? It's all of the blood is pooling somewhere, either internally or externally. And therefore, they may need replacement of whole blood. So you see this as a treatment here listed. So we're going to treat them with red blood cell packed red blood cell transfusion, or they could also get whole blood transfusion. We're also going to treat the cause of their blood loss. So why are they bleeding? Is it an aneurysm? Is it a blood vessel that was ruptured? Is it a nick during surgery? What is it that's causing it? Let's treat the cause so that they stop bleeding, right? And also, symptoms-wise, not only are you going to get the pallor, pale, brittle, and overwhelmed cardiovascular system, but you may also, depending on where the blood is, you're going to see blood, or it's going to be pooling internally. So then watching for distension or swelling somewhere. So if the blood is pooling in their abdomen, we're watching for abdominal distension, right? If it's in their leg, we're watching for swelling in their leg, bruising, purpura, coughing up blood, bleeding out of orifices, things like that. Anywhere, any other internal bleeding symptoms. The next type of anemia is sickle cell disease. Sickle cell disease is different from sickle cell trait. It is a genetic mutation of the hemoglobin causing anemia, but just because you have the trait does not mean that you have the disease. So a trait is the genetic predisposition that they carry, but it is not active in their body. And so if they have the trait, that does not mean that they have the disease. They have the trait, that does not mean that they have the disease. Okay, so but they could pass it on to their child later in life. And when they have a child, their child may then have that recessive gene being come to fruition, and they have now the sickle cell disease. So what happens is that the red blood cell sickles inside of in like a half-moon crescent shaped, as you see in this picture on top of the anemia types. The left is the normal, what it's the red blood cells are supposed to look like. They're supposed to have a little dip on one side, little concave sort of circular disc. However, in the case of sickle cell disease, not trait disease, the cells don't fully form into this shape, or they can revert back into a sickled shape due to many things. Due to pain can cause it, dehydration can cause it. We'll go into a couple of different factors in a moment, but the sickled cell doesn't carry oxygen. It doesn't carry anything that the body needs. It's also very sticky. And so they're very fragile and sticky. So they often can cause these vaso-occlusive crises. So you see in this picture where they all clump together, and essentially it's a clot of sickled cells. And therefore anything beyond this is no longer being perfused. And this can happen in any vessel in their body, and this is very, very painful. So the sickle cell disease clients, their pain is severe. So I have pain listed here for a reason. Pain to the point that it could be disabling. It can cause organ damage due to this occlusive crises. They're also at an increased risk for infection and early death because of their poor perfusion that can happen anytime, several times daily. Depends on the client. It's not daily in everyone, but it's a possibility. And so that poor perfusion to their entire body can cause many issues. So when sickle cell disease clients do have normal concave hemoglobin cells, like on the left side, we want them to stay normal shape. Just because we have a couple of sickle cells rolling around, it's not a big thing. It's an issue when they all start sickling, because then they become sticky, right? So preventing them from clumping and preventing them from sickling is our goal. So staying hydrated is and oxygenated is our two main goals in prevention. After it's already occurred, our goal is pain and perfusion. Pain is first. Okay, so if we have impaired perfusion, remember, long-term can cause tissue and organ damage. But anytime that this happens, even if it's for an hour, 10 minutes, 2 minutes, there's some scar tissue that organ could have infarcted for just a moment. But that tissue is now a little bit weaker than it used to be. It may be pumping fine and acting fine. Kidney function is great. Again, the next 5 minutes, but during that time, and then now it's have that damage, that kidney eventually is going to shut down if these crises continue to happen. So we are wanting to prevent the frequency and severity of these attacks, because this can be quite damaging to their entire body. So again, our goal for management once they have an vaso-occlusive crisis is pain. And then we're going to hydrate them and prevent any infections, giving them oxygen, transfusions, whatever we need in order to promote those cells to stop sickling and open back up. So pain management, hydration, warm environment, anything to open up, vasodilate those vessels so that we can get perfusion back and preventing infection. Okay. Next, we have G6PD deficiency anemia. This is an X-linked recessive disorder that occurs in 10% of African Americans, Middle Eastern, and Asians. Usually no symptoms in these clients until they are exposed to a triggering agent. Usually this is some sort of virus, but it doesn't necessarily have to be a type of virus. But again, these clients don't know until something triggers this reaction, and then we find out that, oh, they have this genetic disorder because of how they reacted to this. But it's usually after a severe infection. So what happens is that acute red blood cell breakage occurs, so lysis. The cells are breaking apart. This can happen for 7 to 12 days, which is a very long time, and can lead to anemia and jaundice due to the hemolytic reaction. Jaundice, remember, is the yellowing discoloration. Usually we associate that with the liver, but why we're associating it with the liver is the bilirubin, right? Bilirubin is released when these cells are lysed and broken apart. So that bilirubin being circulated in those high volumes causes this jaundice effect. Now, hopefully when we start producing new red blood cells from the bone marrow, or we give them a transfusion, that jaundice should go away if it has not caused any damage. But we do need to flush out that bilirubin, right? So in treatment for this, we're going to try to prevent this, especially if we already know. We also, once we know, we want to prevent damage, especially kidneys. So if we are treating an infection and this occurs in a client, and they start breaking down these red blood cells and start to develop jaundice and anemia, we want to save those kidneys. So what usually happens is we'll give them mannitol. They may need a blood transfusion to try and kickstart that faster than the, waiting for their body to reproduce red blood cells. Just go ahead and get it refilled, essentially. Refill the tank with appropriate red blood cells and flush out those broken up red blood cells. Now, an iron deficiency anemia is next. This is the most common type of anemia. It's often a result of blood loss, poor GI absorption of iron, or an inadequate diet of iron. So, if we were to test most of the population, I would bet that 50% of us at least are iron deficient anemia. This is usually because in North America, we don't really have a great diet, but we also have, genetic predispositions that we just don't absorb the iron correctly. So a big thing here is going to be education. So preventing this with diet. So red meat, organ meats, egg yolks, which has been a big fad to go eat without the yolks. So this is another reason that we're even more deficient lately. Kidney beans, leafy green vegetables, and raisins. If a client is so severely iron deficient that we need to give them supplements, we do have PO supplements that they can take, but education for them to take it with meals is important, with meals, to increase that absorption of it. And then if we're going to give them it through an injection, we can, but it is quite painful, very thick. So we try to prevent that if we can. So this is usually treated with diet management. Other symptoms for these clients, and beyond just the normal weakness and pallor and fatigue, they're going to also may have fissures in the corner of their mouth due to that deficiency. In their iron level, the ferritin is usually less than 10. So this is unique for this type of anemia. Now, vitamin B12 deficiency. This is a failure to activate the enzymes to move the folic acid into the precursor red blood cell in order for cell division and growth to occur. So it needs folic acid to do vitamin B12. So sometimes this is an issue because they're folic acid deficient that's causing the vitamin B12. So there could be a couple of different reasons for vitamin B12 deficiency. Diets lacking proteins, clients that have small bowel resections or chronic diarrhea, diverticula, tapeworms, or an overgrowth of intestinal bacteria are usually these type of clients. Now, pernicious anemia is a type of vitamin B12 deficiency anemia, and pernicious anemia is a result from failure to absorb because of a deficiency, a genetic deficiency of an intrinsic factor. And this is may be related to an autoimmune disorder. So they start attacking their own intrinsic factors to then they can't break down and can't absorb the vitamin B12. So that is a type of B12, pernicious anemia. The unique symptoms of vitamin B12 are the jaundice due to the breakdown of the cells, as well as glossitis and paresthesia, so numbness, tingling, usually of the extremities, but does not necessarily have to only be in the extremities. And then that glossitis is a smooth, beefy red tongue. So this is unique for these types of anemic clients. We're going to treat these with animal protein diet. with fish and eggs and nuts and dairy products and all the things that I just don't eat. Dried beans, citrus fruits, and leafy green vegetables. PO-wise, normal regular vitamin supplements have vitamin B12 in them, so just taking an over-the-counter vitamin. Or we can also have them prescribed an IM injection, which is usually weekly. And we'll do this in the cases of pernicious anemia to help hopefully stop the body from triggering itself to kill itself, essentially. So if we can be like, no, 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 every week, sometimes the body will, okay, well, never mind, I will stop fighting this. But not always. That's just how I think of it. For pernicious anemia. Now, vitamin B12 deficiency, that you can also get an IM injection. You don't have to be pernicious in order to have the IM injections, but usually it's like a one-time or maybe once every 6 months if it is an issue more than just diet or that you're just severely lacking in your diet. Next, we have folic acid deficiency. So again, remember, folic acid is needed for B12. So folic acid and B12 deficiencies are quite common with symptoms because you need one for the other. So folic acid also has similar symptoms, but the paresthesia is not going to occur until it's come to the point of vitamin B12. So the folic acid could have been the precursors to the vitamin B12, but the paresthesias is from the B12. So folic acid may have the glossitis in this case, but it's not going to have the paresthesia on its own. Folic acid anemia is due to a poor nutrition diet, lacking in green vegetables, leafy vegetables, liver, yeast, citrus fruits, dried beans, and nuts. As you can see, most of these are very similar. The clients that have a malabsorption disorder, such as Crohn's disease, and taking medications or drugs such as anticonvulsants or oral contraceptives can predispose you to this as well. Prevention is the key, so education about the diet and intake is, of course, important, but they can also take a folic acid replacement therapy, which is usually a pill. In aplastic anemia is the picture here to the bottom. So it's an impaired cellular regulation of the bone marrow. And so it starts at the bone marrow. And so it fails to produce red blood cells that are mature. And so due to an injury to the precursor cell. So the precursor or stem cell that was supposed to now mature and become platelets and red blood cells and white blood cells doesn't develop into any of those things. So they are not only deficient and have a low hemoglobin or red blood cell count, but their platelet count and their white blood cell count can also be low because they come from the same precursor cell. This usually occurs with leukopenia and thrombocytopenia, I said that completely misleading. It usually occurs with leukopenia, which is the low white blood cell, and thrombocytopenia, which is the low platelets, because they're all together, right? They come from the same precursor cell, like I was saying. But in this case, that all three are low, we call this pancytopenia. All three are pancytopenic, okay? If it's related to, it can be related to long-term exposure to a toxic agent or a drug, ionizing radiation, or infection. So sometimes, I can't remember the virus, but there is exposure to some sort of virus that can actually lead to and become aplastic anemia if they've had exposure to this virus before. And if they haven't had any exposure to any of these other toxic agents and then continue to look at the cause, it may be just because they've picked up a virus along in their life. And so it can be quite odd, but in most cases, it's a long-term exposure to like chemo, radiation, or medications that affect the bone marrow and immune system, things like that. So if a bone marrow biopsy was to be done on these clients, the fatty part of the bone marrow is shown to be replaced by red cell-forming marrow. I said that backwards. The bone marrow biopsy revealed that what's supposed to be red cell-forming marrow has been replaced with fat. And so they're not producing what they're supposed to be producing. And we're going to treat this by giving them immunosuppressants. We may have to give them blood transfusions. It may be lifelong blood transfusions, because if they're not developing any of these cells that they need for their immune system, for white blood cells, for red blood cells to carry oxygen, and platelets for clotting, they may be on long-term blood transfusions chronically. Sometimes this can be discontinued after the causative factor has been erased and no longer part of their system. So if it is from a toxic drug or radiation or infection that we can treat, great, and it resolves and we start kicking in new bone marrow that's creating the correct cells and precursor cells, and now we're better. Great. But if we've gotten it to the point that that bone marrow is now completely fatty and not cell-forming marrow before we've caught it, we're never going to create, that fat isn't going to return back to cell-forming marrow. So at that stage, it's so far along that it is not reversible. And due to all of these factors and the injury that this can cause on the client, a splenectomy may be required. It may be due because their spleen is going to be enlarged, inflamed, and chronically swollen. It's usually surgery for a better quality of life more than anything. It's not really a treatment. It's not going to cure or fix the problem, but it's going to help with their quality of life, having this splenectomy. And then last, we have immunohemolytic anemia, also known as autoimmune hemolytic anemia. But for both of these, hemolytic is in the name. So remember, hemolysis, the cell is breaking apart. Now, due to unknown reasons, they still aren't sure, antibodies in these clients' bodies are being created and destroy their own red blood cells. So the red blood cells lyse, and that then is followed by the bone marrow saying, oh crap, you need red blood cells, let me make you some, but they're abnormal because it was an oh crap moment. So rapid production of abnormal red blood cells is the unique thing in these areas because it happens so suddenly. And so when we take a differential of the red blood cells, we'll see that, okay, well, the red blood cell level is normal, but we have a high bilirubin, so something is breaking up. But then, oh, it's because these red blood cells aren't mature. So, or they're shaped wrong or whatever. So there's something wrong with them and they're still not helping the situation. Now, the treatment is going to therefore depend on the severity, at what point has the hemolysis broken up, how many cells have been attacked. We may need to give them steroids to suppress their immune system. This is usually a temporary solution, and therefore suppression and new red blood cells can then be created. A splenectomy and immunotherapy may be also required. Or chemotherapy if those fail. So we can try the immunotherapy and get rid of the spleen, but if that fails, then we may have to resort to chemotherapy just to tell the body to stop acting a fool. So their body is just going to keep attacking the red blood cells, and nothing is going to stop it. So essentially, their way of survival is chemotherapy to stop their own cells from killing their own cells. So this can be quite severe of an outcome at times. Now, here are your resources from Chapter 37 for anemia and the sickle cell concept exemplar. But also you have ATI Med-Surg for Chapter 39 and 41. Make sure that you understand the different diagnostic procedures from that Chapter 39. We'll discuss a little bit more in class. So we'll look into different levels of diagnostics instead of just the hemoglobin. And I will see you in class. Thanks.